study is on May-Thurner syndrome with a stent emboli. Okay, we have a 37-year-old male obese patient presenting to the ER with sudden onset chest pain while walking up the stairs. Pain was on the right side, radiating to the back, and right off the back, when you hear this, you automatically think this is an MI. This guy's having a STEMI, and we gotta do a EKG, chest X-ray, check out the blood levels, look at the troponin and the D-dimer. And they did all these tests, and troponin and D-dimer were all within normal levels. EKG showed no abnormalities, and the patient is hemodynamically stable but has acute chest pain. The chest pain is intermittent and positional, and kind of goes away and then gets worse as he moves. And so the patient actually has a history of May-Thurner syndrome and has had a placement of an iliac venous stent to fix that. Now, the ER physician ordered a transthoracic echocardiogram, and it was performed, and it actually showed a tubular structure in the right atrium, extending across the right ventricle, going into the extending across the tricuspid valve and going into the right ventricle and impinging into the interventricular septum. Now, May-Thurner syndrome it's really not a rare syndrome, but no one's ever heard of it because it's commonly never diagnosed. May-Thurner syndrome is actually in 20% of the population, and patients develop iliofemoral deep venous thrombosis from this due to an anatomical variant with the right common iliac artery laying over the top of the left common iliac vein and impinging it against the lumbar spine. To fix this, when patients come to ER with DVT symptoms, they get a lower leg extremity DVT scan, and they'll find that it's a positive DVT, and a coagulation therapy is used for the treatment. But these people keep having recurrent DVTs, and then they explore deeper, and they can find this May-Thurner syndrome with the iliac vein and arteries. For a permanent fix, they'll do an iliac venous stent to keep that vein open. Here are some images of May-Thurner syndrome. On the right, we have a picture of the right common iliac artery coming right across that connection point for the left common iliac vein and the inferior vena cava, and it pinches off that left common iliac vein so that the blood flow is hindered, and then it's more prone to developing DVTs. On the left side of the slide, we got a coronal CT image of this syndrome and what it would look like in a CT image. Now, May-Thurner syndrome symptoms are typical DVT symptoms. They have leg pain, leg swelling, feeling of heaviness in the leg. They have pain with walking, skin discoloration, leg ulcers, and large veins in the leg. And this picture on the right is of a patient that has this syndrome and probably developed DVTs, but also that increased pressure in that venous system in that left leg from that impingement kind of just causes diffuse swelling throughout the whole leg, and we can see drastic differences between these two legs here. You could also note those bandages on the calf area, tibialis anterior area, are probably bandages covering ulcers from pressure ulcers or just wounds from the horrible circulation that's going through that leg right now. With May-Thurner syndrome, we can see that with ultrasound, vascular ultrasound. And we have 2 images that tech took of May-Thurner syndrome. And you can see on this right image, the non-color image, it's labeled with the right common iliac artery that we're seeing in the short axis view. And then we see the left common iliac vein going into the inferior vena cava, and we're seeing that in the long axis view. This ultrasonographer calipered actually before the iliac artery, and then at the point of iliac artery they calipered again to take the measurements, the diameter of that blood vessel, and what that iliac artery is doing to it. On the left side we can see a color flow Doppler through there, and we can see the calipers again. One thing to point out that might be beneficial with a patient with May-Thurner syndrome when we're scanning them is we could possibly caliper during systole and diastole of the heart cycle, because as pressure builds up with systole in that right common iliac artery, it could potentially pinch off a drastic amount more on that left common iliac vein than during diastole. So we could take 2 different images between each cycle of the heart. Now, iliac venous stents are the permanent fix for this syndrome. This image here shows all the anatomy. We have the aorta that branches off into the iliac arteries, and then we have the IVC that comes from the iliac veins. We can see as that right common iliac artery crosses over the left common iliac vein that impinges upon it, and then the small image to the bottom right of it shows where a stent would be placed to keep that from occluding and causing DVTs. Something to point out is as the veins head closer towards the heart, they get wider, and so the stent is narrower at one end and then wider at the IVC end. May-Thurner syndrome can be diagnosed with ultrasound, CT, also intravascular ultrasound, and angiography. Iliac venous stent embolize. For unknown reasons, a stent can become dislodged and become an emboli. Could just be due to the anatomical dimensions. As it widens into the IVC, it becomes more prone to being an emboli. Blood is going back to the right side of the heart and then flows into lungs, and that is the route that the stent emboli will take. Symptoms of this, as the patient gets this stent emboli in their heart, they could have chest pain, shortness of breath, tachycardia, arrhythmias, and syncope. All typical symptoms of what you would think a heart attack would be. This is the short axis image that the ultrasonographer took of this case study, and this patient in the short axis image, you can see that stent is actually in the right atrium going across the right the tricuspid valve and entering into the right ventricle and pushing up against that interventricular septum there. And this is the apical 4 chamber of it, and most of the stent is actually still in the right atrium going through that tricuspid valve, and then it almost looks like it's pushing through the interventricular septum, and that is dangerous. It can cause lots of damage to the valve, the chordae, and the walls of the heart. And treatments of this, they discussed going in intravascularly to pull the stent out, but they determined that it would be too much risk and possibly damaging the heart even more. So they had to do open heart surgery, cut open that right atrium and extract the stent out that way. And while they were at it, they repaired the tricuspid valve and chordae if there was any damage in the walls of the heart. And we can see that stent in the center of where they're retracting the atria there. It's pretty big, and it took up most of the area in the atria. My clinical site actually just ran across this syndrome and a stent emboli, and it took them 10 months, like 5 different echo scans and a few different cardiologists, and every time they scanned and looked at this thing in the heart, they were thinking that this was a bacterial growth from endocarditis. So the patient had many rounds of antibiotics, and it was not going away, wasn't moving. And finally, on the last ultrasound scan, a really smart vascular tech that did echo 2 saw that, and he knew right away that that was a stent that had embolized. And so I talked to a cardiologist, and they determined that it was a stent, and they needed to take it out. And we can see that stent as it flops towards us. See the opening of that stent looking our way. And then here we can see that stent is situated in the right ventricle all the way, and is right above that tricuspid valve, parallel with it, and is probably entangled with the chordae that are holding that tricuspid valve, and it's probably causing some major TR, tricuspid regurgitation, and is not doing any good in there. That is my case study. Thanks.